So we're going to continue Chapter 7 with some very specific procedures and applying the coding guidelines that we have talked about already. So our first is talking about biopsies. And remember from terminology in your A&P classes, a biopsy is a taking of a tissue from a living person for the purpose of a microscopic study. We need to be careful though, because a biopsy code is not assigned when a lesion is removed for therapeutic purposes and is sent to the laboratory for examination, even though the provider may use the term biopsy in describing the procedure. Remember, surgical specimens are routinely sent to pathology for study. This does not make it a biopsy and is not considered a biopsy for coding purposes. Therefore, a biopsy code is not appropriate. So let's talk about the different types of biopsies. And the first one is a closed biopsy. They're performed percutaneously by needle, brush, by aspiration, or by endoscopy. Most of the biopsy codes have been revised to include an endoscopic biopsy. If a biopsy code does not indicate how it was performed and it was done by an endoscopy, you'll need two codes. First the endoscopy code and then the biopsy code. A brush biopsy is when mucus or exfoliant tissue is removed using a brush or a bristle to collect cells for cytological examination. It is coded as a closed biopsy if there is no separate code for a brush biopsy. An aspiration biopsy collects cells for examination by aspiration, and you would code that as a closed biopsy. An open biopsy is when there's an incision, and the incision is implicit in the biopsy code. When the approach is implied, such as a bone biopsy, no additional code for incision of the skin is required. When a biopsy is incidental to the removal of other tissue during a procedure, you're going to want to code the more definitive procedure first, followed by the biopsy code. When a diagnostic exploratory procedure is performed for diagnostic purposes, more than just as a simple operative approach, and a biopsy is completed at that time, you're going to want to code both the biopsy and the exploratory procedure. So let's talk about open versus closed biopsy. A needle biopsy for the removal of a small sample of tissue is performed during an open surgical procedure would be coded as a closed biopsy, even though the cavity is open. So the fact that they used a needle to collect the specimen makes it a closed biopsy. The type of biopsy is determined by the technique used to obtain the tissue. So that's very important, especially when we're talking about open procedures. The terms open and closed in this connection do not refer to the surgical approach used to gain access to an internal organ. When discussing biopsies, we need to be in tune to the sequencing of the biopsy versus the definitive procedure. When there's a definitive procedure, it is always sequenced first, with the additional code for the biopsy second, even though the biopsy is performed before the definitive surgery. In that case, we see that people have a biopsy, and depending on the results of that biopsy, like in a frozen section, then they do a more definitive. You would still want to code both of them, but we're going to be coding the therapeutic or the definitive procedure first. Sometimes procedures are canceled after the patient has been admitted. So we need to review the record and determine when that procedure was canceled. A code from V6-4 category, persons encountering health services for a specific procedure not carried out, would be added to the record. We would not code a procedure code if the surgery was not started. Okay, so you got to be really in tune to that. It's possible that they identified or developed a condition that contraindicates the surgery. Maybe the patient has decided not to go through with the surgery. That would go to code V64.2. Or there could be a problem with an illness of key staff, or maybe the physician not being available, problems in scheduling in the OR, maybe a trauma patient comes in that trumps an elected procedure. For those cases, we would go to V64.3. If a procedure has been started but it is not complete, we're going to want to code it to the extent to which it was performed. So think about what was done. You're going to want to review the op report. If an incision only is made, you're going to code that incision. If they applied and used an endoscope for an approach, but is unable to reach the surgical site, you're going to code the endoscopy only. If a space or cavity was entered, you're going to want to code exploration of the site. So it's very important to read the extent or the details within the op report. Procedures sometimes are referred to as failed procedures. And when they say failed, it means that it did not achieve the hoped for result, or maybe every objective of the procedure cannot be accomplished. We're going to want to code that to the extent that the procedure was performed. So read again through the op report and determine the extent of the procedure. There is no code, or that failed procedure should not be considered a complication. So let's talk about the various types of shunts that you will see. They're often referred to by the name of the device, such as the Denver or the Levine shunt. And these shunts are used for a variety of purposes. The codes are assigned based on the intent of the procedure and the procedure that's involved, rather than just the name of the shunt, because here again they could have multiple purposes. You're going to want to look for the words creation, formation, or shunt in the alphabetical index. When you're reviewing the record, sometimes you will see that a previous shunt has been revised. So you're going to want to look at the op report to determine the portion of the shunt that is involved in that revision. So an example would be our ventriculoperitoneal shunt. You're going to want to see if the peritoneal site was revised, if the ventricular site was revised, or if both sites were revised, then assign an appropriate code for both. An externalization may be performed because of recurrent infections. This procedure may be performed at bedside, and it involves the incision of the anterior chest wall. The shunt is externalized and connected to an external drain for the purpose of combating the infections. The code would be 8609, other incisions of skin or subcutaneous tissues. Tubular metal implants designed to restore blood flow by opening or enlarging a blood vessel and maintaining patency are examples of intravascular stents. They're used to treat threatened vessel closure or abrupt vessel closure. Drug-eluting stents refer to a stent with an active drug that is released in a controlled manner. Conventional stents and drug-covered or drug-coating stents are coded as non-drug-eluting stents. Codes are also provided for other types of intraventricular insertions, such as the carotid artery, going to code 0063, other extracranial arteries, going to code 0064, and intracranial vessels for code 0065. In addition to the intravascular insertions, stents may also be inserted to other examples. So we may see a stent inserted into a bile duct going to code 5143. If it's coded or completed by an endoscopy, you would assign a code 5187. Pancreatic transhepatic insertions of a stent go to code 5198. And then a stent that is inserted into the colon is code 4687. If it's performed by endoscopy, the code would be 4686. There's also additional codes for stent insertions, identifying the number of vessels that are treated, going to codes 0040 to 0043, and then the number of stents that are inserted, and you'll find those in codes 0045 to 0048. These codes apply to both coronary and peripheral vessels. If a procedure involves a vessel bifurcation, you're going to want to use code 0044, procedure on vessel bifurcation, to show that procedure. Stereotactic radiosurgery is used for the treatment of brain lesions and tumors. It is also used for arteriovenous malformations and functional disorders, such as what we would see in Parkinson's disease, epilepsy, and intractable pain. Computer-assisted surgeries are becoming very commonplace now. These are reported with a code for the very specific procedure that's performed, and then a code from the category 00.3. Computer-assisted surgery is classified based on the different imaging modalities that are used. So if you look on the right, you'll see that we have computed tomography, magnetic resonance, fluoroscopy, each going to a different code within the 00.3 subclassification. Robotic-assisted surgeries are classified based on the approach, and if you look, we'll see that open goes to 17.41, laparoscopic to 17.42, percutaneous to 17.43, and on. The robotic-assisted surgeries are reported with the code for the primary surgery first, followed by the code to show the robotic approach. So to give you an example, a total laparoscopic robotic-assisted cholecystectomy is first coded to 5123, laparoscopic cholecystectomy, and then we need an additional code, 17.42, to show that it was a laparoscopic robotic-assisted procedure.